hypercapnia is more common in COPD, while in case of pneumonia, type 1 failure are more common than type 2. That is, hypoxemia is generally more common than COPD.
And what are the investigations that we can do?
So first on presentation, so chest X-ray will, if reveal features of hyperinflation, that will give a picture of COPD. While in case of pneumonia, sir, they can be picture of non-homogeneous obesity, which can be present on a chest X-ray, which can be a consolidation confirmed by a CT scan.
Major Ram, how will you differentiate an exacerbation from a acute PT or an left ventricular failure?
Sir, yeah, we can differentiate by clinically. If he's having failure, he will having fluid overload. He'll having pedal edema, sir. And PT, we can do he can have hemodynamically unstable, sir. Plus, on ECG, there can be specific changes which can be seen, sir. Like in LV failure, we can LV strain pattern, LVH.
And any clinical probability score that you can use?
Sir, in PESI score can be used in PT, sir.
What else?
Or well score.
Better. So these are the differentials which include pneumonia, pneumothorax, effusion, pulmonary embolism, and heart failure. Next. At the time of admission, what are the prognostication scores that we can use for COPD exacerbation? Major Sudhindra.
Sir, to gold criteria to differentiate severity, sir.
Okay. What are the other scales that we can use on OPD basis or while admitting a case of exacerbation?
Sir, CAT score.
Those are अच्छा ठीक है बैठिए कृति अग्रवाल. Any prognostication scores that you know of?
So the Rome criteria gives us mild, moderate, or severe exacerbation, sir. So depending on the.
What about DCAF score? DCAF score. Shamsha? DCAF score. What is it used for?
Sir, for mortality assessment, sir. If we are admitting the patient, it will give the mortality assessment. Sir.
In hospital mortality.
In hospital.
And what is the score that we use for OPD mortality?
Board index, sir.
This is the DCAF score, which includes basically dyspnea, eosinopenia, consolidation, acidemia, and atrial fibrillation. These are the 5 points. And our patient had a DCAF score of 3, which comes into severe risk, high risk for mortality. The other score that we can use is a board index. This is used on OPD basis to predict mortality. Next. Major Satish. How do you define an acute exacerbation of COPD?
Patient will be having acute sudden onset breathlessness. Then chest pain may be there, associated with the wheezing, tachypnea.
And any cough or expectoration?
Will be present.
And what is the usual time period?
Early morning or
the duration that the patient worsens in? 14 days. Yeah, the duration is usually within 14 days. But an exacerbation is an event which leads to increased dyspnea, cough, and sputum production. These events happen within the last 14 days. And it may also lead to tachypnea and tachycardia and systemic inflammation. Next. How do we define severity based on the treatment that we have given? Dr. Rajesh? Mild, moderate, and severe, how do we define? In mild, what will you do?
Sir, LAMA.
Acutely breathless patient in exacerbation, you will give short-acting drugs, na?
Yes, sir.
Saba and Sama.
Yes.
Short-acting bronchodilators. That will be mild. If you have treated with steroids or plus minus antibiotics, then what do you call that exacerbation?
Moderate.
And when does it become severe? If the patient needs hospitalization.
Oxygen supply.
Hospitalization. If the patient is hospitalized or even if he has presented to the emergency, that means it is a severe exacerbation. But who was speaking about Rome criteria? बताइए. What are the parts of the Rome criteria?
Sir, the degree of breathlessness that the patient presents with as per the visual analog scale, the respiratory rate, the heart rate, the SpO2, sir, and that can be used in the room criteria, and the CRP if available, sir. So a visual analog scale breathlessness of more than 5 goes in favor of severe, SpO2 less than 92, heart rate of more than 95.
But
And
when does it, out of these 5 criteria, how
3
many?
out of 5 should
If
be
3 are
yes.
present, it becomes moderate. And when does it become severe?
pH of less than 7.3.
Acidemia. If acidemia is there, yeah,
Yes.
then it becomes severe. Right. Major Francis. What are the indications for ICU admission in a case of COPD exacerbation?
Sir, if an initial management with short-acting drugs and oxygen supply, oxygen administration, the patient is not improving or presenting illness is more severe with complaints of
Major Neetu. But
Sir, presence of any acidosis, respiratory acidosis, if you're seeing the
need
type.
for IMV or NIV.
Yes, sir.
Any hemodynamic instability.
Yes, sir.
What else?
ABG we'll analyze for
But
type 2 respiratory.
so the criteria are hemodynamic instability, worsening hypoxemia or respiratory acidosis, changes in mental status, and need for invasive mechanical ventilation.
My patient was managed by nebulization with levosalbutamol and ipratropium every 20 minutes for 4 hours, and oxygen supplementation was given via nasal prongs at the rate 2 liters per minute to maintain a target saturation between 88 to 92%. He was administered antibiotics, injections of Trixone 1 gram IV 12 hourly, and a tablet azithromycin 500 mg OD. In addition to that, he was given oral steroids. That was tablet prednisolone at 40 mg OD. Nebulization was continued 6 hourly and on an SOS basis, along with proton pump inhibitors, pantoprazole 40 mg OD, and injection LMWH 40 mg SCOD for DVT prophylaxis. After 1 hour of nebulization, his pH improved to 7.30, PCO2 became 54 millimeters of mercury, PO2 increased to 65 millimeters of mercury, and bicarbonate was 28 millimoles per liter.
Captain Kiran. What is the role of steroids in COPD exacerbation? How do steroids help in an exacerbation?
Sir, steroids they have anti-inflammatory properties, so they decrease inflammation and airway obstruction, edema, sir.
What are the outcomes that they change?
Sir, they decrease they decrease short-term mortality, and they also help in prevention of relapses. COPD
Right.
exacerbations.
So steroids basically shorten the recovery time. They improve lung function as well as oxygenation, and they also reduce the risk of treatment failure or relapse. And the usual preferred dosage is 40 milligram of prednisone for up to 3 to 5 days, and it is usually given orally. Next. When will you give antibiotics in a case of COPD exacerbation? Dr. Anjana?
Sir, if there is an underlying infection, then antibiotics are indicated.
Any criteria then that we can apply? Anthony's criteria. Major Dipankar? बैठिए. So the 3 cardinal symptoms include increase in dyspnea, increase in the sputum volume as well as purulence. Or if out of these 2 are present, one must be purulence. And if the patient requires any mechanical ventilation support, including invasive or non-invasive, then we should be giving the patient antibiotics. And Antibiotics reduce the short-term mortality by 73%, treatment failure by 53%, and sputum purulence by 44%. Any microbiology resident? What are the common organisms implicated in for exacerbations of COPD?
Sir, in bacteria, it could be Haemophilus influenza, strep pneumoniae, Moraxella catarrhalis, and in the viral etiology, it could be influenza virus, parainfluenza virus, rhinovirus, respiratory syncytial virus, and we can even see in the COVID also, sir, exacerbation of COPD.
Any atypical organisms besides viruses in bacteria?
Atypical, sorry. Mycoplasma, sir.
Mycoplasma and chlamydia.
Chlamydia also, sir.
Betty. Dr. Rajesh, in a COPD exacerbation, what are the bronchodilators that will you give, and what is the route that you will prefer?
Sir, MDA, oral route, sir.
For bronchodilation.
Nah.
Betty. Dr. Firdosh, what are the drugs that you will give?
Sir, beta-2 agonist can be given, sir.
Short-acting beta-2 agonist and short-acting anticholinergics.
Yes, sir, anticholinergics.
And what is the preferred route? How will you give it?
Sir, in acute exacerbation of COPD, sir, this can be given through nebulizations.
Usually nebulization or even MDI is equally effective.
Yes.
Betty.
Thanks, sir.
The nebulization should usually be air-driven. It should not be given with an oxygen source. And intravenous methyl xanthines like theophylline are out these days. They are not given. Dr. Srinivas, when will you give a patient non-invasive ventilation?
Sir, when there is a respiratory failure.
Or how do you define that?
PCO2 less than.
More than 45?
More than
40. And acidosis?
And acid.
What else? Dr. Rahmat?
Sir, respiratory acidosis, when there is a use of axillary muscles of respiration, severe hypoxemia, not responding to supplemental oxygen therapy, we can use NX.
Betty. It can also be given in severe dyspnea, which is leading to fatigue and persistent hypoxemia. Captain Shashi. How does NIV benefit a patient of COPD exacerbation?
Sir, it will wash out excess carbon dioxide, sir, from body.
To treat the hypercapnia part. What else? Any outcomes that the NIV changes?
Sir, it will reduce muscle
mortality. It decreases the mortality. Captain Aman. What else does NIV do?
It improves the oxygenation, sir.
Betty. Next. So NIV basically is used for correction of respiratory acidosis and hypercapnia. It improves oxygenation, it reduces the work of breathing, it reduces the severity of breathlessness, and it reduces the rates of intubation and mortality as well, and decreases complications. Surgeon Lieutenant Shamsha, how will you monitor a case of exacerbation whom you have put on NIV?
So the patient first, after putting the patient in NIV, sir, we usually monitor through ABG, sir. Like we can check the whether the
what are the parameters that you're looking at?
So for hemodynamic instability, first we have to check the patient's vitals. We have to be checked, sir, and patients we have to see whether the patient is getting oxygenated correctly, like oxygenation part is correct or not. Then through ABG.